That was a great session before. We're going to start our next session. We're going to be talking about Beyond IO and TKI. We have four fantastic speakers that are going to be giving us talks today. We're going to start off with Dr. Kevin Courtney first, talking about HIF-2 alpha.
Good morning. Thank you. It's my pleasure to present a sort of clinical update and overview of hypoxia-inducible factor II alpha inhibitors. So the learning objectives for this presentation, the current FDA-approved uses of HIF-2 alpha inhibitor, the approved one, belzutifan, are the following. It's in the treatment of patients with clear cell renal cell carcinoma and von Hippel-Lindau-associated tumors. And we'll also discuss updates on studies involving HIF-2 alpha inhibitors, including novel agents. Following on Dr. Gatalia's excellent talk, I'll be very brief in this introduction. Most in this room audience don't need a lot of background on hypoxia-inducible factors. These are key components of oxygen sensing. They're comprised of a HIF-alpha subunit, of which there are 3 identified, with HIF-2 alpha being the critical element in association with renal cell carcinoma. They're capable of binding to HIF-1 beta to form a heterodimer transcription factor. So under conditions of normal oxygen tension, HIF-2 alpha becomes hydroxylated on canonical proline residues. This permits recognition by the VHL tumor suppressor protein, leading to targeted proteasomal degradation of HIF-2 alpha. In the setting of hypoxia, HIF-alpha species are capable of binding to HIF-1 beta with persistent expression of the protein. This leads to transcriptional activation with engagement of hypoxia response elements to promote the transcription of proliferative, survival, metastatic, and angiogenic signals. In an estimated 95% of patients with sporadic clear cell renal cell carcinoma, they have tumors with defects in von Hippel-Lindau expression or activity, and loss of VHL results in constitutive activation of HIF-2 alpha as a driving component of pathology. So as a consequence, a lot of effort has been spent exploring mechanisms of targeting either HIF signaling or downstream components. Now, as a transcription factor that is not enzymatic and that is not a nuclear receptor, targeting HIF itself was long felt to be a significant challenge. But for years, we've had available a number of different tyrosine kinase inhibitors that are approved for use in the treatment of advanced renal cell carcinoma as downstream effects of upregulated HIF-2 alpha signaling. These include multiple different kinases targeting VEGF receptor, as well as antibody targeting VEGF itself. But as we all know, these treatments are not cures and are associated with significant toxicity. And so efforts were made to try to target the interaction between HIF-2 alpha and HIF-1 beta for therapeutic gain. To summarize many, many years of work, very briefly, efforts led primarily at UT Southwestern by Steve McKnight, who was one of the original identifiers of HIF-2 alpha, as well as Rick Brewitt and Kevin Gardner, identified a binding pocket in the PAS-B domain that would interfere with the interaction between HIF-2 alpha and HIF-1 beta and generated a number of different target compounds, which then carried forward through Peloton Therapeutics to identify an initial first-in-class agent to disrupt this interaction. So these are the current approvals for this agent, which is belzutifan, in the treatment of patients to disrupt HIF-2 signaling. Currently, and this is your Monday morning talk, HIF-2 alpha inhibitor belzutifan is approved for the treatment of adult patients with von Hippel-Lindau disease who require therapy for associated renal cell carcinoma, central nervous system hemangioblastomas, and pancreatic neuroendocrine tumors not requiring immediate surgery. It's also approved for the treatment of adult patients with advanced renal cell carcinoma following treatment progression with a PD-1 or PD-L1 targeted therapy and a VEGF receptor tyrosine kinase inhibitor. So going back 3 years to the seminal paper that was associated with approval in patients with VHL. These were patients who had tumors that did not require immediate surgery. And you can see here of 61 evaluable patients, 60 had measurable tumor assessments. 0 out of 60 had progression on the study, and 60 out of 60 either had stable disease or partial responses. And in the right-hand panel, I like to show this tumor reduction procedures plot. You can see before the solid line the number of procedures these patients had to undergo for tumor reduction prior to the start of belzutifan treatment, and to the right of the line following treatment on the trial. So the most updated information was presented by Brian Rini at ESMO this year for the final written analysis of LIGHTSPARK-005, which is the phase 3 study of belzutifan compared to everolimus in patients with previously treated refractory advanced renal cell carcinoma. This was a 1-to-1 randomization, and you can see that this study demonstrated it met the primary endpoint of progression-free survival. Although the median progression-free survival was identical for belzutifan compared to everolimus, followed further over time, there was a significant improvement and separation of the curves. There was not a statistically significant difference in overall survival, but notably, the key secondary endpoint, overall response rate, favored belzutifan significantly with a 22% versus and less than 4% response to everolimus. So how do we build on that further? Well, also presented just recently at ESMO was a randomized phase 2 study comparing, which is LIGHTSPARK-013, comparing 2 different doses of belzutifan. This was prompted by the fact that tolerability, as Dr. Catalia mentioned earlier, is reasonable and safe and manageable in most patients treated with belzutifan. So they compared 2 different doses, 120 milligrams, which is the FDA-approved dose, and 200 milligrams, as the maximum tolerated dose had not been reached in the phase 1 dose escalation study. The overall results showed a similar response rate and no differences with respect to PFS or overall survival, and similar grade 3 and 4 adverse events at these 2 doses. So there are a number of phase 3 trials looking at combination therapy, as belzutifan has only modest efficacy in heavily pretreated patients in the monotherapy setting. These are 3 different LIGHTSPARK trials for which we're awaiting the readout, that have all completed enrollment, moving earlier and earlier in the disease state, second-line therapy, first-line therapy compared to different combinations, and in the adjuvant setting, testing the addition of belzutifan to pembrolizumab as compared to pembrolizumab plus placebo for high-risk patients who underwent nephrectomy. This is not the only HIF2 inhibitor in clinical studies. Eric Jonas and colleagues presented study, phase 1/2 study of NKT2152, which is a novel oral HIF2 inhibitor, similar mechanism of action to belzutifan, disrupting HIF1 beta interactions. On the left, you can see the waterfall plot showing the efficacy in evaluable patients. The overall response rate was 20% with a median progression-free survival of 7.4 months. And similar to data seen for belzutifan, the treatment-related emergent adverse events were to be expected as on-target effects, including anemia, hypoxia, fatigue, and dyspnea. Now, I want to take a few minutes at the close to discuss identification of acquired resistance to belzutifan. So having the opportunity to look at mechanisms of resistance can inform novel approaches to treatment. And this harks back to early data, and for those of you who were able to attend the preclinical session on Thursday, you had the opportunity to hear excellent presentations by Jim Bergerolis and Qing Zhang for looking at their efforts to identify mechanisms of resistance. This is just a simplified summary from one of those, where using patient-derived tumor grafts of renal cell carcinoma and exposing them to treatment with PT2399, which was a precursor to belzutifan, acquired resistance mutations could be identified in the PAS-B binding domain of HIF2 alpha, as well as mutations in HIF1 beta that would either respectively prevent binding of the molecule or permit engagement with HIF1 beta despite binding of these inhibitors. We were able to carry this forward in a clinical trial with PT2385. This was a companion study to the precursor to the belzutifan. In this study, one of Dr. Burril's patients who had undergone serial biopsies, we were able to identify in biopsy M4, shown up to the right, an acquired mutation which recapitulated the mutation seen in the tumor grafts, which disrupted the ability of HIF-2 alpha to bind to the inhibitor. So this led to the rationalization of targeting HIF-2 alpha through a different mechanism using small interfering RNAs to prevent HIF-2 alpha RNA production, targeting a HIF-2 alpha RNA with siRNA to renal cell carcinoma with a target to integrins. Here you can see the results reported this year from the first in human phase 1 study of this tumor-directed siRNA against HIF-2 alpha. Modest response rates as well as some toxicities with polyneuropathy, but as a proof of principle demonstrates methods for exploring treatment following resistance to HIF-2 inhibition. So what are the take-home messages for Monday? Once again, the HIF-2 alpha inhibitor still on Monday is approved for the following indications: the treatment of patients with VHL not requiring immediate surgery who have renal cell carcinoma, CNS hemangioblastomas, and PNETs, and for the treatment of patients with advanced treatment refractory renal cell carcinoma. Thank you.
That was great, Kevin. That was great, Kevin. Thanks a lot. Next up is Dr. Naomi Haas, who's, of course, our winner this year of the Eugene P. Schoenfeld Award. Congratulations on that. We're looking forward to